much for joining this virtual lecture series, which is now the third in the row, and we're going to continue that at least for the foreseeable future. And it's my great pleasure to introduce Dr. Laura Huckins, who's been with us since 2016 and has been part of, just started here as a postdoc and is part of the faculty with a joint appointment in genetics and in psychiatry, and has expertise in doing research in the field of genetics, large databases, especially focusing on traumatic events, post-traumatic stress disorder. So all very relevant that she's going to present on, which is obviously the sequelae of COVID-19. She was trained as an undergraduate in the Imperial College, which is in London, and then did her PhD in psychiatric genetics at Cambridge in the UK, and is now part, as I said, of the faculty. So I'm very much looking forward to, Laura, to your presentation. And this is part of a new initiative that she started with some of our faculty and GGS Genetics to trace COVID patients. So Laura, thanks very much. Glad you want to share these data with us.
Thank you. Thanks for the introduction. I'll just wait while my screen loads here. Of course, it's taking a minute.
Yeah, there you go. Excellent.
Okay, so as Dr. Khan mentioned, I'm going to be talking about our efforts to profile COVID-19 symptoms and sequelae throughout the community. So really the motivation for this study, back in early March, I think all of us here in New York realized that we were going to be the epicenter in the United States, and that Mount Sinai itself was likely to end up as the epicenter of the epicenter. And as researchers, you know, the number one thing that we need in order to fight diseases is data. And we realized that most of the data that we would have access to would not be sufficient to answer the kind of questions that we were facing in New York. So a lot of the data that we were seeing was coming out of Asia. It was coming out of countries in Europe with socialized healthcare. It wasn't really appropriate in order to understand our New York City population. So our goal was to come up with a way that we could reach everyday New Yorkers rapidly, easily, and kind of longitudinally. So the goal was really to come up with a very easy system that any New Yorker could use. So we were kind of inspired by the Notify NYC app. Back in early March, they launched a COVID Notify NYC version where you could text a number in order to receive daily updates about coronavirus through the city. It struck us that this, you know, you don't need to have an iPad, you don't need to have a computer, you don't even need to have regular internet access, right? As long as you have a phone, which most people in the city do, you are able to participate in that phone number. And we very much wanted to emulate that for our study. So we partnered with a bunch of folks in HPIMS and some vendors, and I'll talk about who they are later in the talk. We came up with this text-based outreach survey. So anyone can join by texting COVID to 64722. And then they complete very
strict.
Sorry, I didn't catch that. Was there a question? Okay, I'm going to continue, and if I missed a question, then my co-host Eric will flag that and I'll try and answer. Okay, so the idea is that anyone can text COVID to 64722, complete a simple survey, and they receive this survey every day. So it gives us a longitudinal opportunity to kind of monitor symptoms throughout the city. So our key goals, the first goal, as I said, is daily citywide surveillance of COVID-19 symptoms. Crucially, we have the power to look outside hospitals. So we came across a very worrying survey completed by the Evidation Group back in early March, which showed that for people without healthcare and without health insurance, they would not seek any treatment for their COVID-19 symptoms under any circumstances. And 20% of responders endorsed that question. And many of you who were watching the news obsessively at the time, as I was, will recall that that's when there was a lot of different messages coming out from the government about whether people would be able to get free treatment or not. So this worried us greatly that there would be a large number of people throughout New York City who do not have access to healthcare, will not seek healthcare. So any data that comes purely from hospitals will not capture those people and contagion rates in those communities. We also know now that COVID-19, a large proportion of individuals who are infected will be either asymptomatic or have mild to moderate courses of the disease. So having an outreach-based app allows us to capture those mild and moderate cases rather than just looking at people who are intubated and who end up in hospitals. So we might get a more kind of full picture of the disease throughout the city. And finally, we were very keen to capture things that might be specific to New York City. So I already mentioned we've got disparities compared to European countries and with healthcare access and those kind of things. But we also have other factors that make us unique in New York City. So we have incredibly dense housing. We have people living with housemates who aren't their family members and they're not related to. That's pretty unique to New York. We have incredibly high usage of things like buses and subways. So there's many ways that New York is going to be very different to the rest of the states and to the rest of the world. We also know, and as you can tell by my accent, we have a huge amount of immigration to New York City. A lot of people weren't born in New York. This allows us to test the impact of various different vaccination programs, for example. So the vaccines that you get as standard, things like the BCG vaccine across Europe, people don't get as standard here. And we have kind of the perfect experimental setup in NYC to test the impact of those different backgrounds and circumstances on COVID-19 infection rate. Yeah, as I said, we have the daily citywide surveillance. We come up with citywide surveillance of COVID-19 risk factors. So as well as the symptoms, we're tracking things like asthma, lung cancer, IBD, all of those different disorders that may or may not increase your COVID-19 risk. And most importantly, we're generating a COVID research ready cohort. So we're capturing, I think at the moment, roughly 50,000 people throughout the city who are willing to answer questions about COVID. And what we found is that New Yorkers actually are very keen to participate in this research. We have a very high uptake from the general community. And our goal has always been to portray this as something that we as New Yorkers are going to work on together. This is a way that any New Yorker can help out and kind of help us to further research from their couch. That was our goal. And I think people have really kind of listened to that message and very much want to do whatever they can to help. So that's been fantastic. So we've had to move incredibly quickly. So we initially formed our task force on the 19th of March. Our initial folks from the PsychGen division was myself, Paul O'Reilly, and Alex Charney. We're all PIs in PsychGen. Dara Meyer is our project manager, and without her, we wouldn't get anything done at all. And Clive Hogarth is a postdoctoral fellow in Paul's group, and he's responsible for a lot of the predictive modeling that you'll see later in this talk. On the 1st of April, we officially launched the Stop COVID NYC app. And this was the ad that you saw earlier. This was a really nice kind of watershed moment for all of us to see this really come alive in only 2 weeks. To go from an idea to an ad and to everything being live and accessible was kind of amazing. We received a good amount of local, citywide, and national and international press. So we got a nice write-up in the New York Times, for example. And that helped us pretty rapidly get a large number of responses. So by the second day, we had more than 10,000 responses. By the 5th of April, we had more than 25,000 responses. By the 15th of April, we were officially 2 weeks in and we had 100,000 total responses, which gave us a very nice symmetry to the number of days and the number of people. So we created our first data freeze at that point. And then as of today, we actually have more than 300,000 total responses, about 47,000 baseline surveys been filled in across 37,000 unique users throughout New York. So what this tells us is that not only are people enrolling us in our study, they are staying enrolled. So people are completing on average 10 surveys each, so that they really have, signed up to this daily filling in their symptoms, tracking their symptoms every single day, which is really nice. So we have some solid longitudinal data there. So most of the results that I'll be talking about in this talk come from our 15th of April data freeze. This is what our daily survey looks like. So any of you who have signed up to this will see this is very familiar. This is designed to take less than 1 minute a day. we're very pleased to see that of those 300,000 responses that we've had, the average daily completion time is 52 seconds. So we're very pleased to be successful with that less than 1 minute daily check-in goal. So basically, users are presented with a checklist of their symptoms. They can select any that they've experienced within the past 24 hours. We make certain to send these text messages out late in the evening so that we are capturing the entirety of that calendar day. So there's a lot of different research about how to send out surveys in different times and those kind of things. So these go out around sort of 6 to 8 p.m., depending where you are in the list. And we hope that this gives us a really good estimate of what people have actually experienced that day. We ask them how bad their symptoms feel on a scale of 1 to 10, so from extremely mild to the worst symptom they've ever had. And then we ask whether they've left the house today for any reason. If they select yes, they then also get a follow-up question. Did you use the bus or subway, and how many face-to-face interactions did you have? And then we also ask whether or not they've been tested for coronavirus, and if they have, whether the test was positive or negative. Our one-time only questions, so our baseline questionnaire, these questions you get upon enrollment. So when you text that number, you complete our consent bot, you complete these one-time only questions. These take a little bit longer. The whole survey takes on average, I think, 4 minutes and 40 seconds, something like that. And this is the one that 47,000 people have filled out. So they tell us their age, they tell us their smoking history, they tell us all kinds of things about their risk factors, pregnancy, job, demographics, all those kind of things. So as I said, the first data freeze captures the first 2 weeks of our app usage from the 1st of April to the 15th of April. We had 105,000 data points in total. The key questions that we're asking with that very first freeze is our collection strategy working? So are we actually able to reach out? I think I've given you some spoilers there by saying things like we had 100,000 people fill it out and it took less than a minute a day. We wanted to know whether we could predict a positive test status. I hope we have Clive and Paul on the call who can answer some more in-depth questions about this. They've actually been running that kind of prediction model, but I'll give you a brief description of how that works. We wanted to know whether symptoms and outcomes differ by zip code. So the data released by the NYC government, the NYC .gov website shows data from hospitals per zip code, right? So we aren't getting necessarily the full picture. We're getting the picture of people who can get tested, which we know is a biased sample, and people who can afford healthcare, which is again a biased sample. So we want to see whether our study does any better than that. And finally, we also wanted to know whether New Yorkers were complying with the social distancing behaviors and regulations put in place on March 22nd on the NYC on pause guidance. So to start with, who is using our app? It's majority women filling out our app questions. I think that's standard. We expect that whenever we do a survey-based outreach, women are more likely to sign up. The ages, it's actually pretty encouraging. So a large number of people are between 19 and 39, but 14-ish% of people are over 60. And that's roughly equivalent to what we see in the NYC.gov census data from the previous census. So we're actually getting a good representation of all age groups. We have worked incredibly hard to make this accessible for the kind of over 70s, over 80s age groups. So things like having a clickable list of symptoms was a deliberate choice to enable kind of older users throughout the city. We also have an email line and a phone line manned kind of 24/7 that they can get in touch and ask questions about. So I think all that effort is kind of reflected in those older users. And as I said, the baseline questionnaire takes about 4 minutes. This 20,000 users completing the baseline questionnaire is as of the 1st of April. So like I said, that's now up at 47,000. Race, ethnicity, as we would expect, we have slightly more white Europeans than is represented throughout the city. That, unfortunately, I think is also what we see with a lot of studies. We have a distinct underrepresentation of Hispanic Latino folks. So that should be, I think, around 20%, and we only have 10%. We are hoping to launch our survey in Spanish and written Chinese to improve some of these numbers. We also know people have a wide range of pre-existing conditions. So we selected 9 pre-existing conditions that they could choose in a checklist. And then we also had a number of common write-in entries. So for example, 101 people wrote in that they had seasonal allergies. And the vast majority of users of our study have never or rarely smoked. So this is our very first data snapshot of symptom profiles across New York City, and this is basically coming from our daily surveys. So 8,000 people reported having no symptoms at all. The next most common were headache and runny nose. So these are not symptoms that we would typically associate with coronavirus. But there are kind of more than 1,000 people reporting loss of smell or taste, shortness of breath, diarrhea, these things that we do know are more associated with COVID. On the whole, users are rating their symptoms as not particularly bad, so the average is 1, so very mild. However, among these people, roughly 500 have had a coronavirus test, and of those, 250 have tested positive. So we can see whether any of those symptoms are over or underrepresented among those who test positive in our app. And indeed, we see that some are significantly different among those people. So people who test positive are significantly less likely to report having no symptoms, and they are highly significantly more likely to report loss of smell or taste, shortness of breath, fever, or high temperature. And these other bold ones reach nominal significance, but aren't significant correcting for multiple testing. What's especially nice to see is that things that we would associate with seasonal allergies, so itchy eyes, runny nose, but not with coronavirus, there is absolutely no association with having a positive test. So there's a nice kind of null controls that we've included. We also see that people who who have a positive coronavirus test rate their symptoms as significantly worse than the general population. So that's also kind of reassuring that we're having this profile of worse symptoms and of coronavirus related symptoms among those individuals. Of course, these straightforward symptom profiles don't tell the whole story, right? So we as researchers know that we can't create a model based on 15 independent variables. There's going to be a lot of collinearity between these variables. There's going to be a lot of overlap. So whether you as a user select fever, high temperature, or chills, that may just be sort of your personal preference in how you describe your symptoms. Whether you select body ache or headache, again, there might be a lot of collinearity there. So we took these data and then created a more sophisticated prediction model. Now, the other thing to note is that getting a test itself is not a neutral situation, right? There are certain symptoms that predispose you to qualifying for a test. Especially in early April, we saw that individuals presenting with a fever or high temperature, that was one of the testing criteria itself. So we would also see an enrichment of fever, high temperature in individuals who test negative for coronavirus. And actually it's the fact of being tested is associated with fever. We also know, of course, from many of the media articles that there are various demographic factors that predispose people to getting tested or not getting tested. Race, ethnicity has a huge bearing on whether you're able to get tested, as does income, zip, all these kind of things. So we pulled all this together. This model is created by Clive Hogarth in Paul's team. What we're looking at on the x-axis here, I'm just going to talk about the plot on the left, is your chance of being tested given your symptoms. And actually there's a typo here, I'm sorry, this should say the chance of being tested given your symptoms and your demographics. And on the y-axis, the chance of testing positive given that you get tested and your symptoms. So we're sort of accounting for the symptoms that would predispose you towards getting tested. The main symptoms that come out as significant in this model are shortness of breath, loss of smell, and I think dry cough is a negative predictor. So that actually predisposes you to testing negative rather than positive. And we're able to do a pretty good job at predicting who might have a positive test. So on the left, this is our training data taken from our baseline surveys. And you can see that the red points are individuals who test positive. And we're able to pretty clearly distinguish this cluster with positive tests from this cluster at the bottom here with almost no positive tests. So next we want to know whether symptoms differ by zip code. This is our map of New York City that we're all very familiar with here on the left. And this is showing symptom scores for all of our participants in each zip code. So the darker the color, the higher the average symptom score in that zip code. On the right, we're showing the level of deaths per zip code from coronavirus. And we can see that we have a very high correlation between average symptom score in each zip code and the number of deaths. In fact, our correlation between symptom score and deaths is higher than the correlation between proportion testing positive and deaths. So we're pretty confident that using this method, we are doing a good job at capturing contagion rates throughout the city, and perhaps even a better job than the kind of preliminary testing data that's available. Our next goal here is to look at change per zip code as well and see whether we can model the average change in symptom score and whether or not deaths are decreasing in each zip code, and see whether we can predict when a decrease is about to happen, which obviously is going to be vital for us to understand, are we ready to stop social distancing, for example? What steps do each zip codes need to take? Who's still at risk? And all those kind of things. So our final question with the preliminary data is whether New Yorkers are complying with social distancing. So as I mentioned at the beginning, we asked all our individuals whether they left the house, whether they used the bus or subway, and how many face-to-face interactions per day they have. So in general, New Yorkers are complying pretty well. Roughly 50% of individuals are leaving the house each day. Roughly 2% of individuals are using the bus or subway. This is very much in line with the data that we're seeing from NYC.gov, which is showing a 95% reduction in subway usage throughout April. So we're pretty closely recapitulating what we expected there. We see that individuals are less likely to leave the house over time. So there's a significant downward trend. Unlike what we're seeing in popular media or social media, there hasn't been a relationship in our data between the weather and the likelihood of leaving the house. So when we correlate the temperature, the feels like factor for the temperature, the wind, the rain, the hours of sun, there's no relationship with house leaving. There is some slight increase on the 11th, 12th. We think that's kind of a perfect combination of it being the weekend, it being Passover, and it being Easter. And that leads to a slight increase in house leaving here. So these factors aren't level across all different groups of our study population. So I mentioned in our baseline survey, we're capturing things like employment categories, and we actually split out the social distancing behaviors by employment category. What we found is that healthcare workers treating COVID patients, as we would expect, are the most likely to leave the house. So roughly 80% of them are leaving the house every day. It's not shown here, but 20% of them are using the bus or subway every day. The next most likely group to leave the house are service occupations, so people working in food and cleaning industries, supermarkets, that kind of thing. They also are leaving, roughly 60% leaving the house. And again, sort of 15 to 20% of them are also using the bus, subway every day. So clearly these individuals are not able to comply with social distancing regulation. We also see that those top two categories, healthcare treating COVID and service occupations, are having on average 3 to 4 face-to-face interactions per day. So they're still seeing and interacting with a lot of people. We wanted to know next whether sick New Yorkers are staying home. So because we're able to capture symptoms every day and behavior every day, we can ask questions like, does your symptom score today predict your behavior tomorrow? So if you have fever today, are you less likely to leave the house tomorrow? And actually we see that all of the symptoms that are associated with coronavirus, so fever, shortness of breath, tiredness, weakness, dry cough, chills, all negatively predict leaving the house tomorrow. So in general, people have understood that if I feel sick, if I have these symptoms, I must stay inside in the future. There was no relationship between seasonal allergy symptoms, so runny nose, sneezing, itchy eyes, and leaving the house. These look significant, but actually they aren't significant when correcting for multiple testing. If we make a score of the symptoms, so if we more highly weight those symptoms that we know are more associated with coronavirus, so loss of smell, taste, for example, we see an incredibly significant relationship with not leaving the house tomorrow. So in general, sick New Yorkers are staying home. However, there is no relationship between using the bus and subway and staying home and having symptoms. So for some groups of people, those who are using the bus subway regularly, they aren't able to modify their behavior based on their symptoms. And when we look at this more closely, we see that this is actually due to service workers and healthcare workers treating COVID patients who are not able to stay home if they experience symptoms. So clearly we have a small proportion of New Yorkers who are sick, who are still moving around the city, and who are still, unfortunately, having to use our public transport system. So I think there's some pretty important insights for us there about how we treat people working in those categories. Just noticed I have a question in the Q&A box. I can't get it to open. Eric, could you send it to me as a message or read it out if it's a...
Laura, we'll do that at the end of the talk. Then
okay, perfect. I'll do that at the end. Okay. All right. So the next angle is mental health for our survey. So we all know there are going to be enormous impacts of COVID-19 on our mental health. Most obviously, social distancing is going to be a huge concern. So we've shown that the average New Yorker is having fewer than 1 face-to-face interactions per day. That in itself is a huge stressor and a huge trauma for all of us to be that socially isolated. However, on top of that, we have some factors that I think are going to be pretty specific to New York City. So we have financial worries. We know that the stimulus package from the government is insufficient, and especially insufficient for New Yorkers. It doesn't cover 1 month's rent here, for example. And we know that a lot of our city is undocumented or are immigrants who aren't eligible. So there's a huge concern about how financial worries will impact the mental health of New Yorkers. We're also concerned about a lack of access to support networks, treatment, and therapy. So while many of our providers have been able to transition to telehealth, that doesn't account for the informal chosen family support networks that many of our city use. So there will be a gap kind of in the usual support that people are used to for their mental health needs. And we also know that we're starting to see gaps in the provision of sort of more basic needs. So some of the supermarkets in Brooklyn, for example, are closing down or on strike. There's going to be a big issue with access to food, protective equipment, and so forth. And I think we're already starting to see substantial worsenings of various inequalities throughout our city. So the income gap is widening. There's a lot of racial disparities and systematic racism occurring throughout New York City. All of these things are going to have really substantial mental health impacts. So although the beginning of our study didn't explicitly collect mental health questions, we did ask individuals to report any other symptoms that we had missed or anything else that we should have asked and hadn't. So it's a very broad catch-all area for any COVID-related symptoms. And most people related things like my test was on this day, my wife also had a test, those kind of coronavirus-related data. However, a large number of people also related all of these different psychiatric sequelae and said that because of coronavirus, I have had these various symptoms. And I think they're more or less what we would expect. So anxiety, depression, difficulty concentrating. We do also see things that we might associate perhaps with PTSD, so things like nightmares, subsequent tiredness, and there's some potentially neurological issues there as well, like migraine. So there's clearly a great need to capture mental health impacts of coronavirus throughout the city. In line with this, we created a COVID-19 questionnaire, which will go live on our app in the near future. Says today, it's not going to be today, I'm sorry about that. We keep hoping the survey will launch. We're working to get this done as soon as possible. So basically, our mental health survey will go out once a week to all participants in the app. We will capture general mood anxiety questions. So this is based on the PHQ-9, which I'm sure we're all familiar with, users, participants on this call. So we'll ask them whether they feel nervous, anxious, are they able to stop or control their worrying. At the bottom there, we have 2 questions that we've added in pretty much because of coronavirus. So are they restricting their food intake? Are they binging on food? Partially, these are because I'm first and foremost an eating disorders researcher, but also we've seen a lot of anecdotal reports from eating disorders groups saying that people are nervous or very highly concerned about food instability. So they're restricting to kind of reflect the fact they don't know when they're next going to be able to go to the supermarket. So we should have increased rates of food restriction, and probably the flip side of that, food binging as well. In line with the healthcare workers study that the Dean is working on, we're also asking about coronavirus coping strategies. So we might not, as a community, think of all of these as healthy coping strategies, but I think these reflect what is likely going on throughout the city. So some people will be turning to healthy coping strategies like community service, getting advice, creating structure and routine. Others will be instead increasing substance use or disengaging and venting. So it's going to be very useful to us to capture those different kind of strategies going on throughout the city. Hopefully it can also help us to identify people that we might want to follow up in more detail for things like substance use or alcohol abuse. As I mentioned, we're not just concerned about the impact of social distancing on people's mental health, we're also worried about the impact of financial instability and all those different things. So we're asking them explicitly what are the things that they're most concerned about in relation to coronavirus. We have a PTSD angled questionnaire. So these are kind of standard PTSD questions, but relating to COVID-19. So are they experiencing nightmares? Are they constantly on guard? Are they now more detached? We'll capture those different scales. And again, this will go out weekly. Then at the end of the survey, we have a couple of screening questions for things like OCD and psychosis. So the bottom question is our psychosis screener. And we also have some suicide screening questions that will go in as well. Of course, it's not acceptable to us to present these questions without then giving individuals an opportunity to seek help, right? It's not responsible to ask everyone to report on their suicidality without presenting, a way for them to reach out. So we have this final landing page. This is the end of the survey that they're directed to, and this is just a snapshot at the top of it that shows how to reach out for COVID-19 guidance and support, either through the NYC Department of Health or through these different various mental health and crisis text lines and hotlines. And they're sort of directed to all the various questions that we ask about. So we have an eating disorders question, so they have an opportunity to contact the Eating Disorders Association and so forth. So we hope that everyone who fulfills the study then has access to help through this. So our next steps are to link with various other research studies throughout Mount Sinai. And I think we have probably 6 different calls over the next 2 days to reach out to other groups throughout psychiatry and throughout genetics to kind of team up. We firmly believe that nothing great is ever achieved alone. The best way for us to beat COVID, as I said at the beginning, is to increase our data and increase our understanding. We really want to share our findings and our data and our resources as rapidly and as easily with everyone else at Sinai. We have a research-ready cohort. Any use of that, of course, has to comply with our IRB restrictions, so we aren't able to just do whatever we want, but we are very keen to work closely with other PIs to put in IRB requests, to work out what the right ways to follow up these individuals are. We already have tie-ins to post-hospitalization surveys. So individuals who have been hospitalized for COVID will be followed up through our app. We are tying into healthcare worker surveys, to biospecimen collections, host genetics collaborations, the PsychEmerge network. We're going to try and deploy the same survey throughout the 5 different hospitals that constitute PsychEmerge and many, many others. These are the folks in the New York's COVID Informatics Task Force, or NYCIT. This is grows massively every single day, so there's millions of faces that unfortunately are missing here. But basically to kind of highlight Girish, who is kind of the PI of the whole NYCIT effort. Eddie Golden, who has been just an absolute star at helping us with the IRB application. As you can imagine, this is the largest IRB application any of us have ever submitted, and has been wonderful to have her support. And Matteo, who has been fantastic with getting all the kind of back-end details of getting data from phones to internet to us rapidly and easily. So he's kind of the engineer behind this all. As I said, there's many, 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 many people missing. I'm sure there's people missing from this slide as well. Thank you to everyone who's pitching in. And finally, my lab. I made us take a Zoom photo. Usually we'd have a photo that includes, us out at some fancy restaurant or doing something nice, but in coronavirus times, we have to take Zoom photos. So we all dressed up and did a team photo shoot earlier this week. In particular, Amanda and GIE have been fantastic at pulling data into kind of figures and tables for me very rapidly. And Hilary Duenas is an MD in my group, and she's been very good at helping us understand what kind of questions we should be asking to understand coronavirus. So that's it. And with that, I'll take questions. Thank you.
All right, Laura, thank you very much. This is really a marvelous and great study, wonderfully done and conducted, and providing a lot of very, very important data points, and hopefully for a long time to come, which is really, really very, very interesting. And thanks for taking this initiative and executing it so well. So yes, so if you want to read the questions in the Q&A box, and then you can address them. Thank you very much.
Great. Okay, so I'm going to start with the two that are in the chat box, and then I'll go to the Q&A box. So first up, whether this survey is open to adolescents. So this survey is open to 18 and up. It's an IRB restriction. They have to attest that they are 18 years or older in the consent, and then enter their age again later. So we remove anyone that kind of said, yes, I'm over 18, and then later says they're actually 17. They get kicked out for lying. It would have been fantastic to have this on younger teenagers, I agree, especially from a mental health perspective, but I think it's too difficult to do with phone-based surveys, unfortunately. The next question, what type of association do you see between population density and symptoms/deaths by zip code? Yeah, so we're working on that right now. So we have a number of questions that we want to know about zip codes. So income per zip code, symptom density, number of tests, and number of people leaving the city. All those analyses are ongoing. Hopefully we'll have those answers within the week. We don't have them yet, I'm afraid. What error correction method am I using for multiple comparisons? Usually I run a quick Bonferroni just to correct for the total number of tests. As you've seen, the things that are significant are massively significant. So our score predicting people leaving the house the next day, for example, has a p-value that's like a -169. So I'm pretty confident that any error correction method we used would still pull that out as significant. Okay, let's see what else we have. Have we had a chance to look at gender differences yet? Not yet, but we will. We're also going to look at whether being part of the LGBTQ population predicts any outcomes, whether race ancestry predicts any outcomes. All those kind of demographic questions are coming up. Okay, could we consider adding an Addiction Institute link or contact into the landing page? Yes, so the landing page that I showed was just the top of the landing page. There is an addiction hotline that is available on the landing page as well, so they have access to help. I think we have one for alcohol and one for substance use. Okay. What are our concerns about collection bias and self-report reliability? That is a very good question. We've spent a lot of time thinking about that and how to address that. I think for the symptoms themselves, we spent a lot of time thinking about, when to send the surveys, how to make this as easy as possible. We hope that having a checklist reduces some of the barriers to reporting. So if you ask people to report their symptoms, I think they might write in one or two. Checklists are shown to, increase the accuracy and encourage them to select all the symptoms that are true. For that, there are also definitely some people who are filling in the survey for their mum, for their child, and then kind of telling us in the box at the end. So that's one major concern with self-report reliability, that it's actually report for others. But we're doing everything we can to identify and remove those answers. For mental health, I agree, it is going to be an issue. So we know, for example, that with PTSD-based surveys, your mood today affects your answers more than your mood during the period that we're asking about, right? So if we ask someone what their childhood was like on a day where they have low mood, they're likely to answer differently than on a day where they have high mood. So that's one of the reasons why we need to do this study now during the pandemic, instead of doing a retrospective study in 6 months or a year's time, so that we can get, kind of answers throughout the pandemic while we're still experiencing it, of what people are actually feeling. So our very first question that we ask about mental health, we'll ask them retrospectively all the way back to March 22nd, which is when we enacted NYC on pause. Every weekly survey after that will just ask about the last week. So we hope that self-report reliability in the last week will be pretty high. Okay, next question. Are we planning to add more languages? Yes. So it's originally in English. We then looked at what the most commonly spoken languages in New York City are. Those are Spanish and then written Chinese. So that'll be the next 2 iterations of the survey. Whether we're able to add any more than that, it's kind of difficult. There's an awful lot of difficulties in introducing more languages into a text-based app. So we'll see how that changes our demographics and then assess at that point. How did you decide which mental health symptoms to focus on? And how do we decide to focus on PTSD symptoms? So we started by looking at surveys that were already existing in the community. I work as part of the Psychiatric Genomics Consortium. I'm one of the PIs on the PGC coordinating committee. So we've had a lot of calls among ourselves about surveys that are going out at each institution. So we were pretty careful to try and align those as much as possible. So very similar versions of this survey will be going out at UNC, University of Oslo, all those kind of places. So a lot of that is kind of based on teamwork and harmonizing our data early. Some of it, of course, is based on the fact that I'm a PTSD researcher and an eating disorders researcher, and those are the things that are interesting to me. I do think PTSD is pretty much the highest risk that our community faces right now, especially with these reports of nightmares that we're seeing. The constellation of symptoms from case reports that are being published, from people reporting in our app, it looks an awful lot like PTSD to me. Not being a clinician, just being a researcher, but still it looks like PTSD. Yeah, so we've also tried as much as possible to use clinically validated existing scales. So you'll see that the questions are similar to the CAPS or similar to the PHQ-9 and that kind of thing to maximize harmonization. Okay, next question. Is this solely for data collection? And if someone reports severe COVID symptoms, does a recommendation pop up that they should go to the emergency room? That's a really tricky one. This is only for data collection. We are very clear at the beginning of the app that this is a research study only. This is not a way for them to seek care in real time. With 50,000 people filling the survey in, we aren't able to man that 24/7 and produce reports. We don't think people are reporting accurately enough or specifically enough to actually make medical recommendations based on what they're telling us. However, in the same way as our mental health survey will have that landing page that gives you all the resources for mental health, our standard survey has a landing page that gives you all the resources for COVID symptoms. So you will see, text for Sinai if you're a Sinai patient, text this number if you're a New Yorker, text this number if you don't have healthcare, all that kind of thing. So they will have access to all of those resources, but we don't pick and choose who should be routed to those resources specifically. What else? Are we planning to add questions that might capture the possible cognitive impairments associated with COVID? Please, by all means, get in touch, and I would love for someone else to do that. So yes, it's going to be a huge issue, the cognitive impairments. I think the papers that we're seeing coming out on bioRxiv now, they're pretty recent. So I think we didn't really know about this, unfortunately, when we were doing the latest survey redesign. But yeah, there is definitely evidence of migraine, confusion, dizziness, all these kind of neurocognitive issues. I know there are studies going on at Sinai that we will partner with to do fMRI of participants and of patients post-hospitalization, all those kind of things. We don't have an active plan to implement a survey through the app, but we will try and find another way to study those people. It's not my area, so please email me if you have a better plan.
Okay, I think there's one question from Rita Goldstein, and then we'll close.
Okay.
You see? how
Yeah.
you plan go about enhancing representation of the African American community.
Yeah, that's a tricky one. And as we said, we are under capturing that currently. One of the ways we're doing that is partnering with different folks who are kind of working on that at Sinai. So we've reached out to the, I've forgotten her name, which is terrible, the diversity kind of team to ask about different ways of doing community outreach, making sure our posters and our ads are getting to the right people. We are also planning to have multiple renewed kind of press releases over the next few days to highlight the study again, get it in the press again. I don't know specifically what the number one thing to do is to increase the representation in the African American population, unfortunately, but hopefully all of those things together.
Okay. All right, Laura. Thank you very, very much. There was a lot of a big audience. It's great to see that. This teaches us that this can also change life for the better, because this is much bigger audiences than we usually have. So that's great. Thank you very much. It was a great talk and great interaction with the audience, although it was virtual. And good luck with the rest of the study, and keep us posted, because it's very important. Thanks you all for participating, and hope to see you next week. Same time, same place. All right. Thank you. Thank you, Laura.
Thank you. Thanks for having me.